So I don't really know how to start even this video. It's been so long since I made a video. I have actually quite frankly forgotten what the entire procedure was or what exactly went inside making a video. I'm not even joking here. But anyways, let's get started, I guess. It's been more than a year since I made my last video, and I really was struggling as to what to make a video on, what topic to cover. And before we get into that, as to why I was absent, I had made a community post on that, so kind of explaining as to why I have not been able to make a video for the last 1 year, or I think more than that, a little more than that. But anyways, medical science or the MBBS course, it's a very busy course, and I guess I was a little too busy to actually make a video in the last year, and that has actually not changed. In fact, that has only worsened because this is my final year in the MBBS, my 4th year, and the 4th year is the most difficult year as far as the MBBS course is concerned. So I'll probably be busier, but I really had to kind of get the ball rolling as far as my channel was concerned. I really see that my videos still get views, and people keep asking me in the comments as to if or when I'm going to return or make another video, and they keep also thanking me in a lot of videos as to them getting helped by my videos. So that really affected me. That really fills me with a lot of gratitude for all of you. Thank you very much. And it's been more than a year, so I think my communication is a little rusty, but I think we'll work on it, and by the end of this video I think we'll be back in shape. So anyways, as you can probably see, I have selected the topic on pharmacology, which is autonomic nervous system pharmacology. Now, as far as I remember, I'm too lazy to even go back and check. I think I made an introductory kind of a video on the autonomic nervous system in my channel, but we are all going to cover all of that again in this video, although in a short tone, and will be concerned more with the pharmacologic aspect of autonomic nervous system in this video. Okay, so why I chose autonomic nervous system in the pharmacology, or to start this off, is mainly because autonomic nervous system pharmacology is, barring the general pharmacology, the foundation on which the entire pharmacology is kind of lying on. So you need autonomic nervous system, the knowledge on autonomic nervous system, and the knowledge of the pharmacology of autonomic nervous system for any other systemic pharmacology topic that you choose. So for that, obviously we need to start with it. It would have been even better if we started with general pharmacology. That is the module that you or we as a whole should be covering at the first. But I really thought general pharmacology is a little, it's not very, I don't find it that interesting. You might disagree with me, but it is the most fundamental thing. But I think we'll be okay for the most part dealing with autonomic nervous system, because autonomic nervous system is a very interesting topic. So without delaying any more, let's get started. Now, as far as the autonomic nervous system pharmacology is concerned, let's first get a very close, not very close, I would say very fast view of the autonomic nervous system as a whole. So we know that our nervous system, it has a central nervous system and the peripheral nervous system. Central nervous system, if I say this is the brain and this is the spinal cord, right? Now, what is the autonomic nervous system? Autonomic means autonomous, means on its own, right? So on its own, which means involuntary. Involuntary, which means that there are many actions in our body which we do not need to specifically control, right? We do not need to specifically control, or rather we cannot control on our own. We cannot control our pupils getting smaller or bigger, right? We cannot control our bronchioles getting smaller, or the bronchial or the alveoli getting smaller or bigger. We cannot control the peristaltic movements of our stomach. We can, however, control the finger movements. We can control our arm movements. So these are voluntary and these are involuntary. So these involuntary actions, these are actually what the autonomic nervous system of our body is concerned with. Why I drew the central nervous system, that is the brain and the spinal cord, is because this autonomic nervous system, very amazingly, it also originates from the central nervous system. Just like the peripheral nervous system also originates from the central nervous system as the spinal nerves and the cranial nerves. So not the cranial nerves, the peripheral nervous system is the spinal nerves. So but the autonomic nervous system also is originating from the central nervous system. So where exactly from the central nervous system? Before we go on to that, first, you all already know, but we still will be doing this, that the autonomic nervous system is what? Comprised of two things. First, it is the sympathetic nervous system, and the other is the parasympathetic nervous system. This is what the autonomic nervous system is comprised of. Now, it is seen that from suppose this is the spinal cord, and the spinal cord is actually what? It is the continuation of the brain stem. This much we know from the basic anatomy knowledge. So it has been seen that in the brain stem we have the origin of many cranial nerves, right? Four such cranial nerves. What are they? 3, 7, 9 and the 10th. 3, 7th, 9th, 10th. These four cranial nerve nuclei, they, along with the sacral S2 to S4 segments. So this is the S2 to S4 segments. These constitute what we say to be the parasympathetic system. Okay, the parasympathetic system. So see, here I have drawn in blue, this is the parasympathetic system. So if we are to comment on the parasympathetic system, we would say that the parasympathetic system is craniosacral in origin. Why? Because the cranial part is the 3, 7th, 9th, 10th cranial nerves, and the sacral part is the S2 to S4 segments. What this means is that whenever in our body parasympathetic nervous system, there is some action which needs to be mediated by the parasympathetic nervous system. For example, we'll see to this later, but for example in our pupils, they need to constrict. So for that to happen, the circular muscles of the iris, right, they will contract. So who exactly in the nervous system, which nervous system will bring along this impulse? Obviously not the voluntary nervous system, it will obviously be the autonomic nervous system, right? So which part of the autonomic nervous system? The parasympathetic nervous system. Which part of the parasympathetic nervous system? This we'll see. It will be one of the cranial nerves, more specifically the third cranial nerve nuclei. Okay, so this is what I mean by the parasympathetic nervous system being craniosacral in its outflow, which means that for any impulse which is parasympathetic in origin, the origin always has to be either from the cranial 3rd, 7th, 9th, 10th or from the S2 to S4 segments. Okay, this is the parasympathetic. So just like that, there will also be what? There will also be a sympathetic outflow. Where exactly is that from? That is in the middle portion. Where in the middle portion? That is from the T1 to L2. T1 is the thoraco and L2 is lumbar. So sympathetic is thoraco-lumbar. Thoraco-lumbar in origin. So this is the thoracolumbar. So for example, if I draw this, this is the sympathetic nervous system. Now this is more or less the thing. Now, from our basic knowledge in physiology, which I am hoping that everyone has, we know that for a nerve conduction to occur, what is needed? Obviously, there is a neuron needed. So, for example, if I draw a neuron here, right? So, this is the neuron, these are the dendrites, and from here, this is the cell body, and from here, what? This is the axon, which is the longest dendron or dendrite, and here, this is the terminal, right? So, in the terminal, we have what? Synaptic bulb, right? So, over here, what we see, or rather from general physiology knowledge, we know that whenever an action potential, whenever that is generated, that is actually transmitted by a neuron via its axon. Then, when it reaches the terminal part of the axon at its synaptic bulb, what happens? There is release of a special kind of a chemical which is called a neurotransmitter, right? This neurotransmitter, this will lead to what? This will lead to the regeneration of action potential in the next neuron, and then this will go on. So, this is the flow of AP, action potential. So, my entire very badly drawn diagram, what is the purpose of that? The purpose is only to highlight the use of neurotransmitter. What is the use of the neurotransmitter? The use of the neurotransmitter is to regenerate the action potential coming from one neuron to the other neuron, or rather transmitted from one neuron to other neuron. How is one action potential? How is the action potential transmitted? It is transmitted via the neurotransmitter. So, neurotransmitter is released into the synaptic cleft, and this neurotransmitter, will see to this, is picked up by the receptors present in the postsynaptic membrane of the next neuron, which leads to some events happening, and finally the generation of the action potential in the second neuron. So, if I talk about only these two neurons, this first neuron and this second neuron, this will be called the pre-synaptic neuron, and this will be called the post-synaptic neuron. What is synapse, by the way? Synapse is what? Synapse is a complex which is present in between two neurons, comprised of the axon terminals of the presynaptic neuron and the dendrites of the postsynaptic neuron. Okay, it is a complex, it is not exactly a single structure. Okay, so anyways, this was the importance of neurotransmitters being explained to you. Now let's see as to the autonomic nervous system and discuss the neurotransmitter in relation to that. Now we know that autonomic nervous system, whether be it parasympathetic or sympathetic nervous system, there needs to be neurotransmitter as well in this, because there is generation of impulses and transmission of the same. So what is a neurotransmitter? What is a neurotransmitter in the autonomic nervous system? First of all, let's answer this. See, in the parasympathetic nervous system, this is an interesting question. In the parasympathetic nervous system, the neurotransmitter is always acetylcholine. Acetylcholine, we'll see to this, is called the universal neurotransmitter. Okay, universal neurotransmitter. Why? Because even in the sympathetic nervous system, the ganglionic, let me just remove this, the neurotransmitter in the ganglionic segment is acetylcholine. Now what does this mean? See, let's go back to this diagram. Don't worry if you haven't understood that part. Okay, see, I have drawn the parasympathetic and the sympathetic nervous system, right? But see that I have made a few things here. Okay, no, I already have the black ink, right? So see, do you see this? This is one synapse. These are synapses, right? What exactly are these synapses in between? These are in between two neurons, right? Right. But this is actually more than that. You see, in the autonomic nervous system, the first order neuron, this is the first order neuron, This is the first order neuron, right? First order neuron means the neuron which is coming directly from the central nervous system, that is called the first order neuron. This will synapse not directly with the second order neuron, but rather it will first synapse with something called a ganglion. A ganglion. So what exactly is a ganglion? See, a ganglion, very simple. A ganglion is nothing but the collection of cell bodies. Collection of cell bodies. So we know from our physiology knowledge that a neuron, it will have what? A cell body. This, to be specific, this is the cell body, right? And collection of these cell bodies is called ganglion. So in very simple terms, what I mean to say is that in both parasympathetic or sympathetic nervous system, these neurons will first go and they will synapse into a ganglion. Okay, done. Now from this ganglion, the action potential will again be regenerated, and from these ganglion again second order neurons will come out. Second order neurons from these ganglion, and these neurons will finally reach what? The effector organ. So what I mean to say is that this is the, suppose the stalk, the brainstem, whatever. This is the first order neuron. This is the ganglion. This is the second order neuron. This is the effector organ. Okay. So what I mean to say here is that there are two synapses that we have to talk about. First synapse and second synapse. The first synapse is in between the, in the ganglion, and the second synapse is in between the neuron and the effector muscle, or not the effector muscle, the organ. Understood? The first neuron, the first synapse is in between the first order neuron and the ganglion, and the second synapse is in between the neuron and the effector organ, right? So we need to talk about two synapses. So there will be two neurotransmitters. In the parasympathetic nervous system, this is very simple. In the parasympathetic nervous system, in both these two synapses, the neurotransmitter is always acetylcholine. That's it. Simple, as simple as that. But in the sympathetic nervous system, things get a little tricky. Not very tricky, a little tricky. See, in the sympathetic nervous system, what we are seeing is that in the sympathetic nervous system, for the ganglion, the neurotransmitter will still be acetylcholine. But in the sympathetic nervous system, for the organ, the neurotransmitter is different. Then it will become norepinephrine. This is something that you will have to be very, very, very careful about. Okay. So now you will understand why we say acetylcholine to be the universal neurotransmitter. Because acetylcholine is, first of all, the neurotransmitter for any and all types of synapses in the parasympathetic nervous system, and it is also the neurotransmitter in the sympathetic nervous system for the ganglion. The only places where the acetylcholine is not acting as a neurotransmitter is in the synapse between the sympathetic nervous system and the effector organ. In the effector organ. Okay, that is where the neurotransmitter will be norepinephrine. But there are a few exceptions to this. There are a few exceptions to this rule. What rule? The rule of sympathetic nervous system having norepinephrine. There are a few exceptions to this. What are the exceptions? Exceptions are always the most important thing in medical science. So exception number 1. in sweat glands. So sweat gland will be what? It will be an affected organ, right? It is a gland, so it is an affected organ. So in the sympathetic nervous system, whatever the neurons are which are going and supplying the sweat glands, suppose this is the sweat gland, right? And this is the sympathetic nervous system, sympathetic neuron. So the neurotransmitter which should be generated here, it should be norepinephrine. But this is where the exception comes into play. In case of sweat glands, it has been seen that even although sweat gland is an affected organ, but still, and the sympathetic nervous system is being talked about here, but still the neurotransmitter is acetylcholine. Very, very, very important exception. Why is this very important? This is not just important from a theoretical perspective, this is also important from a clinical perspective. We'll see to this later when we'll talk about a class of drugs called beta blockers. See, beta blockers, that is why we seldom use beta blockers in, it is very much warned against diabetic patients, right? Because diabetic patients, whenever they have a case or they have an episode of hypoglycemia, there are a few warning signs that are given off that they are warned against, and sweating is one of them. So if they are prescribed on beta blockers, what they will do, we'll see to this, they will actually block the sympathetic nervous system receptors, the beta receptors, and essentially all the sympathetic symptoms of hypoglycemia will be blocked except one, which is sweating. Why? Because sweating cannot be blocked by beta blockers. Why? Because sweating is not under the norepinephrine, it is rather under the acetylcholine. So it is a cholinergic, although it is adrenergic, but it is cholinergic. What I mean by that? What I mean by that is it is under the sympathetic nervous system, but it is cholinergic, that is acetylcholine is the neurotransmitter. Another very important exception to the rule of norepinephrine being the neurotransmitter in the sympathetic nervous system is found in our renal blood vessels. In the renal blood vessels, it has been seen that instead of norepinephrine, the neurotransmitter is dopamine. So what will dopamine do in the renal blood vessels? In the dopamine, what it will do is it will lead to a vasodilation of the renal blood vessels. So vasodilation of renal blood vessels, and what this will do, if there is vasodilation of the renal blood vessels, more blood will reach the kidneys, more blood will be filtered, so glomerular filtration rate will go up, so more urine will be produced. So in other words, diuresis. So what is the neurotransmitter that is causing this? Dopamine, not norepinephrine, even though this is the work of the sympathetic nervous system. Now, before ending our discussion on the autonomic nervous system basics, the other thing that we need to talk about are the receptors. So the receptors, as far as they are concerned, if we talk about them, the receptors of the autonomic nervous system. So obviously autonomic nervous system is sympathetic or parasympathetic, so the receptors will also be for either the sympathetic nervous system or the parasympathetic nervous system, right? So the parasympathetic, let's first talk about them. The parasympathetic nervous system receptors, it has been seen, what do we denote them? There are two types of receptors in the parasympathetic nervous system. This is very, very important, and our entire discussion on autonomic nervous system pharmacology will be based on this. There are two types of receptors. One, the muscarinic receptors, and second, the nicotinic receptors. Okay, very, very, very important. Muscarinic receptors and the nicotinic receptors. There are two types of receptors. Each of these two types again have a lot of subtypes, and we'll go on to them later. As far as the sympathetic nervous system is concerned, we won't talk about sympathetic nervous system right now, but just to lay down the introductory structure, sympathetic nervous system, they don't have this muscarinic or nicotinic, this kind of subtype. They have alpha or beta receptors. Okay, this is the bare minimum that you should know, alpha or beta receptors. Now, Muscarinic receptors, let's talk about the parasympathetic nervous system now. See, muscarinic receptors can again be of 5 types: M1, 2, 3, 4, 5. 5 types. Nicotinic, on the other hand, can only be of 2 types. They are not said to be N1 or N2, unfortunately. They are rather called to be NN and NM. Yes, it's written like this. It's not NN like this. No, this is not the way we write it. We write it kind of like a in a small way, the small n, right? So I what do you call this? A suffix. Yeah, it is a suffix, but it's a small suffix, right? So like this we write this. Okay, NN and NM. Let's talk about these receptors for a bit. See, let's talk about the parasympathetic nervous system. Parasymp, nervous system. So as far as the receptors of the parasympathetic nervous system are concerned, we already talked about the muscarinic and nicotinic receptors. Now these muscarinic receptors, these are actually G protein coupled receptors, GPCR. Very, very important. What are GPCRs? How do they work? This is actually a scope of physiology. It is also the scope of general pharmacology. So right now we are not going into that, but just know that if you don't already know, that is, G protein coupled receptors can be majorly of 2 types. It can be the stimulatory type or the inhibitory type. So it can be GQ or it can be GI/O. This GQ subtype of G protein coupled receptors, they are actually the stimulatory type. What does this mean? This means that they increase calcium levels. And GI or O/O, what they will do? They will actually, they are obviously they are inhibitory type. So what they will do is they will decrease calcium as well as other things as well. Okay, calcium is the most important thing, but other things are also, we'll come to this later. Why I'm telling you this is because this M1, M3, M5, these 3, so the odd numbers, these 3 are GQ subtype, whereas M2 and M4, these 2 are the inhibitory type. Remember, in our body, whenever there is an increase in calcium, it is always for what? Most of the times, rather, I won't take guarantee for always, my knowledge isn't that advanced, but most of the times it is due to either a contraction or to stimulate something. Okay, so increase in calcium is very much a stimulatory thing, whereas decrease will be inhibitory, obviously. Okay, done. So these are the muscarinic receptors. Now where are they found exactly? These muscarinic receptors, the M4 and the M5 receptors, they are found in the CNS. And why I am actually starting with M4 and M5 is because as of now they do not have any clinical significance. Remember that this is actually a medical perspective that we are talking about, right? We are studying pharmacology, but we are studying it from the medical perspective. If we were studying it from a pharmacologist's perspective, we would probably have delved deeper into this. But from a clinician's perspective, M4 and M5 are, as of now, in the future we can obviously discover more things, but as of now they are not clinically significant. So we only have to know that they are in the CNS and that's it, M4 and M5. And M4 we already know there is GI and M5 is GQ. M1, M2, M3 are the three receptors where things get interesting. M1, M2 and M3. Where are they found? I think I had said this in my previous video, I don't know. See, M1 is found in two places. In the CNS again and in the GIT, gastrointestinal tract, especially in the stomach. M2 is found in the heart, very, very, very important. And M3 is found in everywhere else as well as the GIT. So GIT is somewhere where there is an overlap, and we'll see to this actually. It is found everywhere else. That is GIT. GIT is the only place where there is an overlap with M1 and everyone else. So just think about it. In the muscles, so in the involuntary muscles of our body. So what are name some involuntary muscles, for example, in the iris. For example, even the GIT stomach muscle, the small intestine muscles, right? Then bladder, in the detrusor muscle, right? So all of these places, all places will find the M3 receptors. Okay. So what exactly their actions are, we'll come to that in a bit. Okay. So or should we cover that right now? Okay, let's cover it right now. Okay. Yeah. Since we are doing this already, so let's do this in a well-fashioned way. Let's not leave things half-baked. See, what exactly is the action? What exactly is the action of the parasympathetic nervous system as a whole? We talked about so many things, but the most basic thing is, what exactly is the action of the parasympathetic nervous system? The first thing that we cleared in this lecture was that the action of the autonomic nervous system is to deal with all those involuntary actions. But specifically what? Specifically what do we mean by that? That we have to now clear up. See, for remembering the actions of the parasympathetic nervous system or the sympathetic nervous system, there is a very easy trick. There is really a very, very easy trick. And this easy trick is, sympathetic nervous system is sympathetic nervous system is sympathetic. That is, it is extremely sympathetic. So if you are very sympathetic, what will you do? You will hold things very close to your heart, and you will, use your heart more, right? So heart will be more. That is what I mean to say. Heart is more. So sympathetic nervous system leads to what? An increase in the heart rate. It will lead to an increase in the conduction. Increase in the heart rate, increase in the conduction. Everything else, it will actually what? Decrease. It will decrease its action. So for example, let's go system wise. Okay, let's actually deal with this right here, right now. For example, let's start with the most basic thing, CNS. What will the sympathetic system do and what will the parasympathetic do? Very simple. Sympathetic system will what? It will decrease cognition. Parasympathetic will increase cognition. There is practical use for each and every of these actions. I can assure you they are very, very important. And there is absolutely no reason for mugging up or for memorizing these, because these things are very, very self-explanatory, right? So for example, CNS, it will decrease cognition, this will increase cognition. Then for example, I was talking about the GIT. GIT, now this is very interesting. See, GIT, let's talk about the actions. So as far as the GIT secretions are concerned, obviously decreased, increased. GIT, the contraction of GIT is concerned. There are two aspects of GIT that we need to see: secretions and contraction. Why are we seeing these two aspects? There is a reason for that. What is the reason? Let's go back. Remember what I had said, that M1 and M3, there is an overlap in GIT, right? They both have actions on GIT. Now let me explain to you what this overlap, or rather how this overlap can be differentiated. What is the difference in their action? What is the difference of the action of M1 receptor and M3 receptor on the GIT? See, M1, as far as its action on GIT is concerned, this will actually increase the secretions, whereas M3 will actually increase the contraction. So they have different actions, but the same site of action. Site of action is same, but their actions is different. M1 will increase the secretions and M3 will increase the contraction of GIT. Okay, very, very, very important. That is why we'll see that when you will use something to decrease the secretion, for example, in the peptic ulcer disease, what do we use? Pyranzepine. It is an M1 blocker. But when we use something like an antispasmodic, which is for decreasing contraction, that is an M3 blocker, right? So these are very, very practical applications of basic pharmacology knowledge. Now let's come back to the actions. So GIT. Now let's suppose since we are talking about secretion, so let's talk about the glands. So any glands secretion decreased, increased. Bronchi, very, very, very important. Bronchi decrease. What does this mean? This means bronchoconstriction. That is, it will constrict the bronchioles, and this is what bronchodilation. This is what a stimulatory effect means, right? Then bladder. This will lead to what? Relaxation of the bladder, right? And this will lead to what? Increase in the contraction of the bladder. Contraction, relaxation, right? Then suppose the something that I was talking about, the iris muscles. So for example, the circular muscles of the iris. Circular muscle of iris. So what this will do and what this will do? This will do what? This will actually relax the circular muscles. So relaxation of the circular muscles means what? This is mydriasis. What does this mean? Mydriasis means that the pupil size will increase. Pupil size will increase. And this is what? Contraction. This is called meiosis. Note the spelling of meiosis, M-I-O-S-I-S, not M-E-I-O-S-I-S. That is meiosis, reductional division. That is in cell division, reproduction. This is M-I-O-S-I-S, meiosis, and this is mydriasis. So meiosis is what? Pupil size will decrease, right? So for example, if this is my eye, this over here is my pupil. So mydriasis means this, and meiosis means this, roughly speaking. Okay. Now the most important organ where the entire difference, or where the formula rather, is broken, which I already talked about, heart. Sympathetic is very sympathetic, so it does everything with a lot of heart, so it will actually increase. This is the only exception. So this will increase. So what does this mean? It means that it will increase the conduction as well as heart rate, whereas this will decrease conduction and this will also decrease the heart rate, right? So these are more or less the uses, or rather how the sympathetic and parasympathetic nervous system works. Now based on these uses, we can also actually see what the uses of parasympathetic drugs will be, or the sympathetic drugs will be. We'll come to that all later. Now let's go back and see where we had left off our discussion. So we talked about the parasympathetic nervous system. I already said that we won't be discussing the sympathetic nervous system in this. The parasympathetic nervous system, the different receptors we talked about, the different work, the functions of the parasympathetic nervous system, and all that we talked about. Now let's move on and look in a little bit more detail as to how exactly the parasympathetic nervous system is working. Let's look into it in a little bit more detail. So now let's move on to the next kind of receptors, which were the muscarinic, or rather the nicotinic receptors. We talked about the muscarinic receptors. Now let's talk about the nicotinic receptors. So see, the nicotinic receptors, we said that the muscarinic receptors, what were they? They were G protein coupled receptors. Nicotinic receptors, on the other hand, very importantly, they are sodium ion channels. Okay, what this means? It means that whenever these nicotinic receptors are stimulated, they will lead to an influx of sodium ions. Okay, and this influx of sodium ion will lead to the effects of the receptor. Now remember that I had also mentioned that nicotinic receptors can be of two types. One is the NN and the NM. Now let's move into a little bit more details of these two types. NN, see this suffix N, this actually you can remember this as nervous. So this is actually present in the nervous system. Where in the nervous system? Remember we had said that there in the autonomic nervous system, in both parasympathetic and sympathetic nervous system, there is what? There is the presence of ganglions. Ganglion, right? So in these ganglions, these NN receptors can be found. Okay, so let's talk about these NN receptors first. See, these NN receptors, first of all, they can be found in the ganglion. So for example, this is the first order neuron. This is the ganglionic, this is a ganglion, okay, and from over here this is the second order neuron will start. So over the ganglion, this receptor is the NN receptor. So in both parasympathetic as well as the sympathetic nervous system, the ganglionic receptors are NN type. Okay, it is also found in the central nervous system as a whole. Okay, so it is found in the ganglion, it is found in the central nervous system, it is also found in the adrenals. Adrenal, okay, the adrenal glands. So these are the three places where the NN receptors are found. And what are these nicotinic receptors? They are sodium ion channels. NM, here the M stands for, you can remember this as muscle. So actually it's not always just muscle, but this actually stands for muscular. So N stands for neuronal and this stands for muscular, which means that NM receptors are found where? In the neuromuscular junction. Okay, in the neuromuscular junction. Now there is a clinical, we will talk about that, the entire clinical aspects will be dealt with in the later videos, the drugs affecting them and what are the functions of those drugs and the name of those drugs and the clinical aspects, all of that will be covered later. But just one clinical aspect I would like to give to you is regarding this, the fact that NN receptors are found in the CNS. So what we have seen is that whenever these NN receptors in the central nervous system, they are stimulated, this causes what? I had just said that nicotinic receptors are sodium ion channels, right? So this will cause a sodium influx where? In the central nervous system, in the cells. And what will this predispose to? This will lead to seizures. So seizure, very important as a clinical presentation of what? Of oh my god, what? This is sometimes corrected by itself, auto-corrected. Anyways, so the seizures are sometimes a very important presentation of nicotinic poisoning, nicotinic poisoning, that is overstimulation of nicotinic receptors in the central nervous system. Now, see, we had talked about these actions of the parasympathetic system, and we had dealt with how they are different from the sympathetic nervous system, exactly opposite. So we will come back to this later. I'm just telling you this. We will come back to these functions later. Right now, let's move on and deal with another thing. Let's very quickly see in a little bit more detail as to how the actual neuronal transmission occurs in the parasympathetic nervous system, obviously, because we're talking about the parasympathetic nervous system in this video. See, in the parasympathetic system, now we are talking about what? Now we are talking about the transmission. Transmission of what? Transmission of action potential, okay, in the parasympathetic nervous system. So, like I had mentioned before, this is from where we had branched our discussion towards the neurotransmitters. The neurotransmitters, why are they required? They are required for the regeneration of the action potential in the next neuron. So, for the action potential to jump from one neuron to another, neurotransmitters are needed. There can also be electric conduction. There are two types of majorly conduction: the electric conduction and the conduction which is mediated by acetylcholine. That is the neurotransmitter mediated conduction, the chemical conduction. But neurotransmitter mediated conduction is the most important and the predominant mode of conduction in our body. So we will deal with that in this. See what is happening. Very, very, very important. Suppose this is one neuron, okay, and what is happening is this is the axon, and suppose these are the axon terminals, okay. The action potential, it is actually coming this way. When this action potential reaches these axon terminals, the axon bulb or the synaptic bulb, what will happen is this will actually lead to, suppose, let me give you a closer look of these. So now I am magnifying these things. So what will happen is the action potential has reached, and this will actually what? This will actually lead to a depolarization of this entire membrane, okay. So depolarization of the membrane, neuronal membrane, okay. Now what will this lead to? This will lead to the opening of voltage gated calcium channels. So suppose this over here, let's make a voltage gated calcium channel. So suppose this over here, when the action potential reaches the presynaptic membrane, it leads to the depolarization of the neural membrane, and this will lead to the opening of the voltage gated calcium channels. So what will happen is this will lead to a rapid influx of calcium. Now I had mentioned to you before that calcium in our body predominantly has two functions. It's either to stimulate something or to lead to the contraction of something, of muscles or something like that. So what does this lead to in this case? In this case, what is happening is, in the synaptic bulb we have these vesicles. These vesicles which are loaded with acetylcholine loaded vesicles. What this calcium influx will do is, this calcium influx will lead to the contraction of these vesicles, and what will happen is, suppose this is the membrane, and what will happen is these vesicles, they will move forward and their membrane will fuse with the presynaptic membrane. Why? Because the calcium influx. After fusion, this part is erased and the acetylcholine is given off. So now the acetylcholine actually moves into the, what is this part? What is this place? This is the synaptic cleft. Okay. But before the acetylcholine can reach the synaptic cleft, or before the acetylcholine is even stored in the vesicles, the acetylcholine needs to be formed. It needs to be formed. So let's take a quick look at the formation of acetylcholine. See, acetylcholine, it's the chemical constituents of this is actually hidden in the word itself. Acetyl and choline. So it is actually acetyl CoA and choline. These two, they combine to form ACH. Okay, acetylcholine. So acetyl CoA or acetyl coenzyme A, this we derive from the mitochondria. The mitochondria of our cells, they have acetyl CoA. Choline on the other hand is derived, very important, from the systemic circulation. So from our blood we derive choline. Okay, then what happens is there is obviously, since this is a reaction, and there will obviously be an enzyme, and the name of this enzyme is choline acetyl transferase. So crux of all of this is that acetyl CoA and choline, they actually combine to form acetyl choline. Acetyl CoA and choline, they combine to form acetyl choline, and this acetyl choline, what happens then is that this acetyl choline is then loaded on into vesicles. It is loaded on into vesicles. Okay. Now let's go back. Now that we have seen as to the formation of acetylcholine, let's go back to this. So when this acetylcholine was released into the synaptic cleft, what will this acetylcholine do? Obviously it has a function. This acetylcholine, suppose this is an acetylcholine, this obviously has been okay, let me not give this, let me make this just acetylcholine, otherwise you might confuse it to be vesicle loaded acetylcholine. This is the acetylcholine, free acetylcholine in the synaptic cleft. This will actually go, and this will actually do what? This will actually bind to the receptors on the post-synaptic neuron. Okay, on the post-synaptic neuron there are receptors. Now what are these receptors? These are the receptors that we have been talking about for the last 30 minutes. They are either the muscarinic receptors, they can be nicotinic receptors, whatever. Okay, but they are parasympathetic receptors because we are talking about the parasympathetic nervous system as of now. So they move on and they are actually binding to their receptors, and then they are bringing about the action. Okay, whatever action it is. Majorly that is the generation, or rather the regeneration of the action potential, and thus the transmission continues. Now this acetylcholine, which is now present in the synaptic cleft, obviously it cannot remain so. So what happens is this acetylcholine is immediately, in a matter of milliseconds, it is destroyed. Destroyed by who? Obviously there is a destroyer. It is destroyed by a very important enzyme, which is acetylcholinesterase. Acetylcholinesterase. Okay. This acetylcholinesterase enzyme is present in the synaptic cleft, and this acetylcholinesterase, which is present in the synaptic cleft, is called true cholinesterase. True cholinesterase. It is present in the synapse. Now since we are classifying this as the true, obviously there is something false. There is a false one as well. That is, there is a pseudocholinesterase as well. Where is the pseudocholinesterase? Pseudocholinesterase is found in the blood, in the plasma. So we will see the uses of pseudocholinesterase as well. It is very important in pharmacology, but even more important is the true cholinesterase. Pseudocholinesterase is present in plasma, and true cholinesterase is found in the synapse. Pseudocholinesterase, it has a bunch of other names. For example, it is also called as the plasma cholinesterase, obviously self-explanatory. It is also called butyryl butyryl. I think okay. Butyryl cholinesterase. Okay. So these are the couple of names that are given to it. Anyways, so what I mean to say is that acetylcholine is destroyed in a few milliseconds. That is how long the span of action of acetylcholine is, and this brings about an end of the neurotransmitters, and the action potential is thus transmitted. Okay, this is how the normal functioning is. Now let's move on and let's actually see. Okay, there are two things we can do. Okay, let's do this first. So now there are a few things that we can do. See, this entire transmission that I have actually explained, we have specific drugs which block specific steps of this acetylcholine generation and thus bring about a decrease in the what? Cholinergic transmission, bring about a decrease in the parasympathetic nervous system transmission, because this is what we are talking about. We are talking about the transmission of the action potential in what? In the parasympathetic nervous system. Parasympathetic nervous system is also called the cholinergic nervous system. Why? Because the neurotransmitter in the parasympathetic nervous system, in the entirety of parasympathetic nervous system, is acetylcholine. That is why cholinergic system. So this cholinergic nervous system, we can block this by blocking the acetylcholine, by decreasing its production or whatever. So that we can do by a couple of drugs which aim at different steps of this thing. So remember when I said that the acetylcholine is destroyed by the acetylcholinesterase, what exactly is destroyed? It means that it will again break it down into acetyl-CoA and choline. This choline, very interestingly, it is actually again reuptaken. Okay, this is actually reuptaken. See, now this is actually complete. So this is reuptake of choline. Reuptake of choline. This is again reuptaken and this is reused for production of new acetylcholine. Okay. Now let's see each of these steps and see a few of the drugs which will actually block these steps. Okay. Okay. See, first of all, I said that this reuptake of choline, let's start with this. Reuptake of choline is the most important step of this entire process of acetylcholine generation. In fact, this is the rate limiting step. The rate limiting step of this entire, you might say, process. So, reuptake of choline is actually blocked by, this is the sign of block, it is blocked by a drug called hemicolinum. Hemicolinum. Hemi means half, right? Hemisphere, right? So half, it is actually cleaving the, you can kind of remember it like this, it is cleaving the acetylcholine into half, kind of. It's not actually theoretically or literally cleaving it into half, but you can remember it like this, hemicolinum. Okay. What are the other steps which were occurring? See, acetylcholine was being loaded into vesicles, remember? This is actually prevented by something we called vesamicol. Vesamicol. So, from vesicle, vesamicol. So, acetylcholine is prevented from being loaded into the vesicles by vesamicol. Done. Now, remember I had said that the calcium channel voltage gated, there are voltage gated calcium channels. So calcium reuptake or calcium entry is very, very important for all of this to happen. This calcium voltage gated calcium channel is blocked by aminoglycosides. Very, very, very important. Aminoglycosides, we will see to this later, they are a class of antibiotics, right? So one of the very, very important side effects of aminoglycosides is something that we say to be, and this we will see actually, this is actually called to be neuromuscular toxicity. Neuromuscular toxicity. This is a very important side effect of aminoglycosides as antibiotics. Why? Because aminoglycosides are blocking the voltage gated calcium channels, and thus they are blocking the action of this entire system in the neuromuscular junction. So that will lead to what? Muscles not contracting, and this will lead to neuromuscular toxicity. Done. Then we had seen that acetylcholine, this was actually being released from the vesicles. This is actually prevented by something that we are kind of familiar with. This is called the botulinum toxin. Botulinum toxin, as well as something that we call to be beta bungarotoxin. So pardon me for the lack of space, but I'm kind of managing here. I hope you can see this. Botulinum toxin and the beta bungarotoxin. Okay, beta bungarotoxin is actually an active principle of many snake venoms. For example, cobra, kraits, neurotoxic snakes. Many of the neurotoxic snakes have beta bungarotoxin as their active principle, right? So they will actually block the release of acetylcholine from the synapse itself. Okay, and thus they will bring about what? Muscle weakness, paralysis, right? That is why that is one of the reasons of death in neurotoxic snake bites, right? That is also the reason of death in what we say to be botulism. So let's talk a little bit about botulism. See, or rather not botulism, or let's talk about the botulinum toxin. So what exactly is happening here? We already said where the botulinum toxin is acting. How is botulism is bringing about the death of a person? It is bringing about the death of a person by something that we say to be respiratory muscle paralysis. Right? If my muscles which help in my respiration, they do not work, if I have respiratory paralysis, then obviously I won't be able to breathe and I'll die. That's why patients with acute botulism, they are placed in ventilators, right? There is another clinical angle to this. Many times botulism is seen in infants right after birth. This is a very bad habit. That is why it is often said that pre-lacteal feeding is very, very, very much discouraged. What does pre-lacteal feeding means? Pre-lacteal feeding means giving the baby any kind of food other than the mother's milk after its birth. So this is actually a custom in some Indian households and stuff, that they give honey and something other than that for divinity or something like that, for customs and cultures. And oftentimes what happens is that honey might be contaminated by the botulinum toxin. This might lead to a case of botulism, and this leads to a very interesting you might say presentation, which is floppy infant. Floppy infant. Floppy because obviously you can understand that the muscles are flaccid due to the botulism working, the botulinum toxin working, right? So floppy infant. Okay, done. So these are a few of the drugs that we talked about. Now see, Vesamicol and hemicolinum, these are actually clinically not significant. We do not, you will never see anyone who is prescribed these drugs, because we don't find these drugs in our clinical practice. These are only important to us from the theoretical aspect. Okay. Now, so now that we have somewhat working knowledge of how the transmission is occurring and the drugs and how it's being blocked, let's okay, we haven't actually finished our topic on botulism. We were talking about that. So this is one of the clinical angles. So botulism, or rather the botulinum toxin, Botox rather, we know about Botox, right? So Botox, we have heard about Botox, and where exactly is Botox needed, or where exactly is it prescribed? We know that Botox, what it can do, it is used in the treatment of, it can be used in the treatment of what? It can be used in the treatment of something like you having an abnormal muscle tone. So dystonia, abnormal muscle tone. Then abnormal muscle contraction called dyskinesia. In all these cases, what will Botox do? Botox will actually lead to by causing that inhibition of acetylcholine being released into synaptic cleft, what will happen is it will not let these muscles contract. So there will be relaxation. So if there is an abnormally contracted muscle tone, it will relax that. This is also the basis for Botox being used in cosmetology purposes. Now this is something that we have all heard about. All the old actors getting Botox treatment, the rich actors, or even not just actors, rich people in general getting Botox and all, and some of them looking horrendous as a as a reason of that. So the thing is, all the wrinkles and whenever the skin gets wrinkled and all that, what happens is Botox is relaxing the skin, and the skin creases or the wrinkles, they disappear, and the person looks a lot younger, theoretically speaking. So other uses of the Botox is in something called migraine. So not exactly in the migraine treatment as such, but for the migraine prophylaxis. This is something that we'll see later. Botox actually leads to a decrease in the CGRP, that is calcitonin gene related peptide. Calcitonin gene related peptide release. It decreases this, and in this way it can actually help in migraine prophylaxis. It can also be used in achalasia cardia. Okay, achalasia or achalasia cardia. Okay, but most importantly, it is used for the treatment of dystonia, which is abnormal muscle tone, dyskinesia, which is abnormal muscle contraction, and cosmetology. Done? Done. Now let's take a look, or rather closer look, at the very, very important thing that I was talking about, which is what exactly? The acetylcholine esterase enzyme. This acetylcholine esterase is very, very, very important. I cannot stress as to how important this is. Let's take a closer look onto this. See, this acetylcholine esterase enzyme, if I draw it, it kind of looks like this. This enzyme, interestingly enough, it has two sites of binding, right? We know that enzymes, they often are multicentric binding sites, right? So multiple sites of binding. So acetylcholine esterase also has two sites of binding. One of them is called the esteratic site, and the other site is called to be the anionic site. Now look closely into the names. Esteratic, which means this site will lead to the breaking of ester bond, and obviously anionic site means it will bind to any cation, any positively charged something, right? Anything positively charged, it will bind to that. Now let's look at acetylcholine. See, acetylcholine, the bond between acetate, so let me write acetylcholine. The bond between acetylcholine is esteratic, ester bond, not esteratic, rather, I'm sorry, an ester bond. So that is not what is important. That is important, but more important than that is the fact that choline is positively charged. So you know what is going to happen. What is going to happen? Choline will actually bind to the anionic site, and while it is binding to the anionic site, this ester bond is actually broken by the esteratic site of the acetylcholine esterase, and thus choline and acetyl-CoA, they are released, choline is reuptaken, and then the cycle goes on. This is the entire thing. Okay, done. So this is the acetylcholinesterase. Now suppose I want to increase my acetylcholine. How can I do that? I can do that by blocking the acetylcholinesterase. So the drugs, we will see to this in a lot more detail later. The drugs which block acetylcholinesterase, they will be called as anticholinesterases. Anticholinesterases. And these drugs, think about it and tell me, what will they do? Are they cholinergic or are they anticholinergic? Will they lead to an increase in the acetylcholine or decrease in the acetylcholine? Obviously, they will increase acetylcholine, because you are actually finishing off the enemy of acetylcholine, which was acetylcholinesterase. You are anticholinesterase, so you are my friend. The enemy of my enemy is my friend, right? So they will increase acetylcholine. So if acetylcholine is increased, this will actually lead on to a cholinergic effect. So we'll see to this again in a lot more detail, as I keep on saying. All the drugs which are anticholinesterase, which will block acetylcholinesterase, they will lead to an increase in acetylcholine, and thus they will bring about a cholinergic effect. Okay, done. So this kind of sets our, I think we have discussed almost everything, and this kind of sets the picture for the entire autonomic nervous system. Now what we are going to do is, we'll take out all these receptors, we'll take up these receptors, we'll take up these cholinergic drugs, and we'll discuss them one by one. So we'll start with the parasympathetic nervous system, like I keep saying. That is why I have not even discussed the sympathetic nervous system receptors as such or anything, because we'll take that up in a separate module. Now what is left in our subsequent videos, we'll be talking about the parasympathetic nervous system, about the cholinergic drugs, about the anticholinergic drugs, and all of that will be on the basis of the foundation that we have set here. Hopefully I'll get around to making more videos, and this will not be a one-off thing. But thank you very much if this has helped you, and I'll catch you guys again later. Bye.